sharing this webinar hour with you and discuss the basics of heart disease, which is the #1 killer of Americans. I hope you'll get some benefit from this and be able to share the contents with anyone else you think might need it. So I'm Dr. Ashby. I am a board-certified lifestyle medicine physician. My background is in internal medicine for the past 17 years. And before that, I was a registered nurse. So I've been a professional in healthcare for over 26 years happily. I trained at Yale, and currently I practice lifestyle medicine because it ties very well my passion for health and teaching, education in the health. So this is a webinar. It is an educational session. The information in here, while useful, is not going to replace your personal contact, consult, and follow up with your own primary care. And so I encourage you, if there are specific questions with your own health that you come up with, that you can ask your physician if it particularly pertains to you. And in this setting, of course, I'll be able to answer your educational question. I hope you don't mind if I start with a story. A few years ago, I was actually working in a local hospital ER. And in that ER, a patient was admitted who had been jogging for the new year. In January is about to come again. And the New Year resolution was to get fit. And so he started jogging, and he was jogging with his fiance. And unfortunately, he had an event where he had to clutch his chest and go down and ended up having a heart attack. And he was brought into the hospital. I took care of him for a week in the intensive care unit. And a week later, as I signed off his case to another physician who was taking over, he had had such complications from the heart attack that organ donation was the conversation that I handed off to the next doctor, and he wouldn't make it on life support. And so I share this story oftentimes when I talk about heart disease, because you just never know unless you look into your risk. And it's possible to know your actual number, a risk number for having a heart attack, which is the most common ailment in our society. So he didn't know his risk. He decided to get healthy. He did the right thing, went out to exercise, but it turned out to be a very fatal stress test on the heart. And so this is a background that us physicians see often in the acute setting. And so unless you have a family member who's receiving acute patients, you might not realize how common this is. Heart attack patients are very, very common. So I want to challenge you this hour to think about whether you know what your actual heart disease risk is. What is your risk of having a heart attack or a stroke right now? In the following slides, we're going to discover basically what is the situation, the overall bullet points, the prevalence of heart disease. How do you calculate risk? And what is it besides cholesterol that informs risk? We often thought and were taught that cholesterol is it. If you fix it, problem solved. But we'll learn that it's not just about cholesterol. So what else is there to consider? And once we learn those other things, what are the first steps recommended to begin to prevent or reduce the risks? Any clogged artery in the heart can cause a heart attack. When that clogged artery is in the brain, it causes a brain attack or stroke. Those two conditions are on the same continuum of cardiovascular disease. So when I talk about an event, a heart attack or a stroke, the risk is for both of them. So COVID, we know, has devastated the country and was the third leading cause of death in the last couple of years. It was beat by cancer, which is the second most common cause of death. And in 2021, heart disease still beat out those two common ailments for killing the most Americans in the year. So it remains the #1 cause of death for Americans. hundreds of thousands of people die every year from heart disease. This was the number in 2020. As you saw in 2021, it increased, and it's projected to continue to increase beyond 2023. So if it's so common and so many people die from it, what does it break down to in terms of seconds? The 40 seconds? Well, every 40 seconds, an American suffers a heart attack or a stroke. So by the end of this talk, we will have had a lot of people who could have avoided a heart attack. In general terms, number one cause of death, 18 million Americans suffer from it. It's very common. This is the number of deaths each year. And many people, including most women, the heart attacks are actually silent. This is very important to discuss because knowing this will be important for those who have atypical symptoms, not the crushing chest pain, but maybe just shortness of breath or a little bit of fatigue, which women tend to have, and that may be the only symptom they get. So 80% is preventable. That's very, very encouraging. So cardiovascular disease, the leading cause of death in both men and women. 1 in 3 women die each year of cardiovascular disease, and 2 out of every 3 men in our society has this condition. So let's focus on the reversible portion. If 80% of it is preventable, what are we doing? Where should we begin? How do we focus our attention on the bit that we can do something about? So this is where we begin. If you don't know your risk yet, and you can think of a percent number in your mind when I ask for your percent risk of heart attack or a stroke, this is the portion that will basically help you focus on that. If you're following and you have your phone nearby, go ahead and take it out. Go to the Google browser, and you want to put in the search box ASCV as in Victor, D. And ASCVD stands for atherosclerotic and cardiovascular disease. This is the risk that we as physicians use to help us calculate the benefit of a medication for someone who might have high risk. So if you're going to be prescribed a statin, for example, a lot of physicians will use this calculation to determine if you meet the requirements for a statin. So once you put that search in the box for Google, I want you to take the calculator that says ACC AHA. Okay, so that's the American College of Cardiology and the American Heart Association. They've combined to making this calculator that was that I use in this, and that is very reliable. So plug in those things in your phone, in your browser now, and you should see an image that looks like this. The risk calculator comes up, and this is for patients 40 to 79 years old. Anyone that falls outside of those range, they can still use the calculator, but it is not so reliable, let's say. The calculator was designed to give information is more reliable for people within those age groups. So you put in your gender, plug in your race. This is where I mentioned you will need your cholesterol information. The total cholesterol goes first. The healthy cholesterol is counted. And then look at that, the blood pressure somehow makes it into calculating your risk of having a heart attack or a stroke, both the top number and the bottom number. If you are treated for blood pressure, this is significant. It will take that into account. If there is diabetes, which can be metabolic disease, prediabetes, I also say yes on that. And if there's smoking, and then hit calculate, and you will get a number. So this is a broader picture of that risk calculator, and it will tell you at the end of your calculation, your 10-year risk of having a heart attack or a stroke. Okay. So let's say you're plugging in those numbers in the background and you're starting to get your results, what do those results mean? If your number is anything between 0 and 5%, that's considered low risk. So essentially, in the next 10 years, there would be a 0 to 5% chance of having a heart attack or a stroke. Of course, everyone wants the risk to be 0. Why not? And so, but that's low risk. So there'd be no conversation about a medication if your risk fell within that range. It begins to be questionable and borderline when you're carrying more than 5% risk of having a heart attack or stroke in the next 10 years. So 5 to 7%, if your number is between 5 to 7%, that's borderline. And at that point, we have a conversation about what other risk factors are there and consider a moderate intensity statin. I'm seeing a lot of patients who aren't enthusiastic about starting medication. So what can be done to help reverse the risk or reduce it so that a medication can be avoided? Well, this conversation happens here before things get too advanced. Intermediate risk is if the number calculated is between 7.5 or 20%. And then, of course, high risk would be a much higher number, and the person would automatically be prescribed a very high intensity statin. Moderate intensity statins are still statins, but they're less potent. And so even if the risk fell between 7.5 and 20, most cardiologists and primary care or internists would prescribe a medication, and the patient would have to decline it or continue with it, and of course, do lifestyle changes, which we'll talk about. So I want to focus your attention on the items that you plugged in that can make a difference in the percent that can be changed. Of course, if you're a smoker, eliminating that is an easy fix. If there's diabetes, reducing it, controlling it, eliminating it improves the risk. If there's high blood pressure, improving that improves the risk. And of course, total cholesterol and HDL can impact the number if the cholesterol is controlled. So we see here the beginnings that it's not just cholesterol that contribute to ASCVD risk or cardiovascular disease risk. We see blood pressure playing a major role, and we see metabolic health playing the other major role. So this background can help us understand why in 50% of the people who have a major heart attack or a stroke, they have normal cholesterol levels. If we just reviewed that cholesterol is just part of the picture, blood pressure, metabolic health can increase your risk here. We can see why cholesterol isn't the only thing to focus on. In some studies and some sources, they even say that over 50%, up to 77% of the factors that lead to heart attack and stroke have nothing to do with cholesterol. This is why you have to start thinking about the areas that can be improved in addition to cholesterol. Some of those include family history, which can inform genetics, which can be tested, inflammation, which is huge, and I know all of you can attest or agree with that. Kidney disease, it's often silent in the background, that can affect cardiovascular health. Insulin resistance, which is another component of metabolic health, and very high visceral fat, which can increase inflammation, increase cardiovascular health. So family history details here, women who are under 65 with premature heart disease in the family, that can be a risk factor. Anyone with a very, very high bad cholesterol, there are certain proteins that live on the cholesterol. If that's tested and they're high, they can lead to heart attacks in the apparently healthy, thin marathoners. That's the Lp(a) that you see here. HSCRP is an inflammation marker that if it's high, it correlates directly with cardiovascular health, anything above 2, and other factors. So cholesterol is one of many. I want to focus on the other factor here for the rest of our talk, that is the killer. In the United States, high blood pressure accounts for more ASCVD deaths than any other modifiable risk factor. Modifiable risk factors are risk factors that you can modify, like the cholesterol that you can help, like the diabetes that you can help. If blood pressure is one of those risk factors and it is uncontrolled, it's the one that leads to the most deaths. So if anyone suffers from blood pressure, which is anything above 120/80, they should have a machine at home and they should know how to begin to reverse this very deadly risk factor. Just to expand on that factor a bit, you see that normal is less than 120, which means if the blood pressure isn't 100s to 110s over 60s to 70s, it's high. I know this is a change from before, where people used to think that blood pressure elevation was about 140/90 or above. Well, if it's 120s over 80s, it's already elevated. And so the risk is beginning. And if it's over 130s to 80s regularly, even taking medication in this range, it's actually uncontrolled or poorly controlled blood pressure. So this one deadly risk factor, which we can control, is in our ability to check even on a daily basis with a machine that you can pick up at a local food or drugstore. I describe blood pressure control in these two simple pictures. This is a Lynch and this is a Lynch. This can increase the blood pressure and that can reverse a blood pressure issue in someone who already has high blood pressure. It comes down to simple diet in terms of blood pressure. I've had many patients reverse or decrease or control their blood pressures solely with the foods that they're eating, and check it themselves and continue to check it for months on end, and beyond 6 months continue to have controlled blood pressure just from their foods. So high salt, we know, is a risk factor for having high blood pressure, because when you take in salt, water stays behind it. When there's an increased amount of water in the circulation of maybe stiffened pipes, it increases the blood pressure. So this can start to increase over time. There are many ways to lessen the use of salt, but as you can see, added salt is literally just 5% of the total salt that we get every day. While we cook, or if you happen to put a little salt on your food, it's not what's killing us in terms of blood pressure. It's this amount here that we get from the restaurants, from the foods that we buy, from the frozen foods, from any packaged healthy foods. This is where most of our salt is coming from. Even people who are adding salt to their diet can't compare to buying a can of something that is loaded with salt. So where are the most salty foods? They're hiding in bread. And this was a study done that looked at the 5 saltiest foods in the US diet. Americans often think of potato chips, but they're not even on the top 5. It's bread, it's pizza, it's sandwiches, cold cuts, and soups, which a lot of our older populations often gravitate towards, but is loaded with salt. So bread beat out potato chips as the biggest salt source. One slice can have hundreds of milligrams of salt, and we'll see how much we're allowed each day. 1,500 if there is a cardiovascular disease. But on average, Americans are taking in over 3,400 milligrams of salt each day. So American Heart Association recommends less than 1,500 milligrams, and the average American is taking in 3,400 milligrams. More sources of salt, in addition to the breads, the pizza, the soups. If you look at here, fresh poultry, a lot of people eat chicken, and chicken is actually preserved using some salt. And so if you look at the fresh cuts, even sometimes organic chicken, you'll find that they have to add some salt to maintain the freshness of the product. So that's one major source. And it's higher than cheese, which is on the list. And of course, some mixed pasta. And at last, we see the salty snacks. Just to give you an idea of what reading labels might do, this is a low sodium chicken noodle soup, 140 milligrams. That's the equivalent of having one slice of bread. You can enjoy a bowl of soup, and the same soup that is regular, as opposed to low sodium, will have almost 900 milligrams of salt. So in 1 cup of soup, 1 serving and 8 ounce, you'd have almost the total amount of salt that is allowed for the entire day. This is what reading the labels can do for you when you know what you need to look for based on the condition you're trying to help. In this case, blood pressure, salt, and keeping it to less than 1,500 milligrams a day. Well, how do you do that and salt your food and enjoy tasty meals? Well, there are so many salt substitutes out there. And you don't have to go completely without salt, just a reduction. So they have low salt alternatives, and they have potassium chloride, no salt alternatives. So I will talk a little bit more about potassium and its role here in helping with blood pressure and being a substitute and alternate to the salt, sodium chloride. So if you've never heard of this before, potassium helps to lower blood pressure. And currently, we have a recommendation to increase dietary potassium to 4,500 milligrams or more every day. So instead of taking in 3,500 milligrams of sodium salt, switch that to taking 3,500 or more of potassium each day. Why? When you eat potassium, because it's a positive cation, the body has to get rid of another cation. It often exchanges sodium for potassium. Okay? So you lose sodium in the urine when you eat more potassium. Potassium has an effect on the walls of the arteries. It eases the tension, relaxes the artery walls, which then lowers blood pressure. Okay? So increasing potassium through the diet has been shown in studies, which is why it's now recommended for people with high blood pressure. High blood pressure is defined as anyone with blood pressure above 120/80. Even if they're healthy, if it's starting to creep up, it's likely due to dietary sodium, and this fix can easily help reverse that. So where do you find your potassium in your diets? I know a lot of you probably think bananas, which is really good, tomatoes, which is also very good, but look at broccoli and potatoes. They're very loaded with potassium. And so if you add to your bananas and your tomatoes, broccoli and potatoes, then you have increased your potassium intake for the day. Few other sources of potassium, very rich yogurt and tuna, in addition to the bananas and the potatoes that we talked about. Sweet potatoes are even very high. They're right under the regular potatoes with the skin. With the skin, it's actually also higher. So how quickly can blood pressure respond to these simple changes? Within 1 week. 1 week. So just having a meal plan is enough to help, because the changes have to be consistent over 7 days. And there are many, many studies that show as little as 7 days to 14 days on a meal plan, blood pressure can be improved. If some of you have heard of the DASH diet, it stands for the Dietary Approach to Stop Hypertension. It was a study that was done to see what in the diet can help lower blood pressure. And so the essential findings were that whole grains, fruits, and vegetables with the salt limitations that we just talked about took care of the blood pressure most of the time. So if you have a 7-day or 30-day meal plan and watch your blood pressure and the guidelines we just talked about the deadliest risk factor for heart disease, this will help a long way in not making the heart attack deadly if you happen to have it, because it's so frequent. Every 40 seconds, somebody has it. If their blood pressure is not poorly controlled, they might survive. Okay. A few other things before we stop for questions. Supplements, in addition to the nutritional guidelines that we just discussed, magnesium is another positive cation, like potassium, that helps to relax the blood vessels. So having those two in your diet, in your supplement protocol, can help the blood pressure. Omega-3s also improve the condition of the arterial wall. So by virtue of the cardiovascular health that it gives, it improves blood pressure. Vitamin C, and then calcium, another positive cation. So having a multivitamin regimen that is keeping the potassium, vitamin C, calcium in good standing, in addition to the magnesium, and the omega may have to be separately supplemented, is really an easy thing that can be done to get started with blood pressure management. So I am going to summarize some of the key points that we've been going through because I can't wait to get to your questions. 1 in 3 women die. 1 in 3 women deaths each year is related to cardiovascular disease. 80% preventable. Every 40 seconds, someone in this country has had a heart attack. Most do not survive their very first heart attack. The ones who do are the lucky ones. 2 out of every 3 men are a setup and have already cardiovascular disease. 18 million people in the United States are walking time bombs and don't know it, because this doesn't cause pain until the heart attack happens. In a lot of cases, people don't recognize the symptoms, the early symptoms. They think maybe they're having indigestion when it might be something called angina, which is beginning of poor circulation in the heart. So while we do have a high burden, and this is our #1 killer, it is 80% preventable, thankfully. Now you have a tool that is at your fingertips on your phone. You can share with others. You can know where you stand, if your risk is 5% or less, or is it 5 to 7.5, or is it up to 20%, or is it beyond 20? And if you have a high risk, do you have the killer risk factor, the blood pressure, which is easily modifiable as the first step that I shared with you today by watching the salt, increasing the potassium, and improving the nutrition. So February is Heart Month. It's a few months away, but between now and then, if anyone watching this today is having high blood pressure, it can be resolved, improved, or even reversed with a plan. So I want to thank you for your attention. I want to give you this resource. You can find this book online on Audible, The End of Heart Disease. A lot of physicians and other healthcare providers have a vision that this largely preventable condition can be reduced, at least, as not the #1 killer. And so I hope that the tidbits today have been helpful, and I will take your questions.